Dear all participants and speakers, I would like to welcome you to the AMSA International webinar series. My name is Jeremy, and I will be your moderator for today's sessions for the current view on hemophilia workup and management. First of all, welcome to our webinar. This is several ground rules that should be followed during the webinar. Please change your name on the Zoom to your clear name. The host and speakers will be asked to turn their videos and microphones on. Participants are requested to keep their microphones on mute to minimize background noise and allow the audience to focus on the discussion. You may type your questions using the chat feature of the platform during lecture. These sessions will be recorded and uploaded on Facebook and YouTube of AMSA International. This is the timetable of our events today, and it will be divided into two big sections: the lecture sessions and the competition session. Without further delay, we will proceed to the lecture sessions. The first lecture will be brought by Dr. Lorraine Mary Item, or Dr. Lorraine. Dr. Lorraine completed her education's medical degree in Pamangtasan ng Lungsod ng Maynila and continue her pediatric degree in Hospital ng Maynila Medical Center. And she continued to be a hematologist and oncologist at Hematology and Oncology Unit of Philippines Children Medical Center. She now works as a consultant pediatric hematologist oncologist at Hospital ng Maynila Medical Center, Bataan General Hospital and Medical Center, and Las Piñas Doctors Hospital. To Dr. Lorraine, the stage is yours.
Thank you, Jeremy, for the introduction. Can you already see my slide?
Yes, but not full slides.
Is it okay now?
It is still blank white and okay.
Is it okay? Is it moving already?
Can you try once more? Okay, it's moving now.
This time.
Thank you.
Okay. So again, thank you for inviting me today. I think I should not open my video to accommodate the bandwidth of my internet. I'm sorry for that. And to start with our discussion, I think it is noteworthy to say that the hemophilia per se is a royal blood disease. So it is also known as a royal blood disease. And so I think it will be helpful for us to start the discussion with a royal blood family member. So inevitably, the start of the story will be from Queen Victoria. So Queen Victoria produced 10 hemophiliac descendants and 7 family or female carrier descendants. So actually, Queen Victoria Queen Victoria produced 9 children with Prince Albert. Okay, from these offsprings descended 4 royal family houses or royal houses. So from Victoria, her first child from Prince Albert was born in 1840, came the German royal house. From King Edward came the British royal house. And then from Prince Alice descended the Prussian and Russian royal houses. And from Princess Beatrice, the Spanish royal house. So, uh, again, as I mentioned earlier, from Queen Victoria until the generation of today, from Prince William and Prince Harry, or should we include George and Archie, they have in their family 10 hemophiliacs and 7 female carrier descendants. And so, because of the princely alliances during that time, consanguineous marriage was tolerated. Did you know that Queen Elizabeth and the late Prince Philip are actually both great grandchildren of Queen Victoria? And um, note that the story began during the 19th century, the time when they do not have the laboratory tests for diagnosis and confirmatory of their conditions. They only have the prolonged clotting time, which was only noted during the 1893. It was first noted among hemophiliacs during approximately the 1890s. And the associated decrease in levels of factor 8 and 9 was initially identified just in 1947 and 1953. So the questions are, how were they able to diagnose the royal family members at that time? And how were we able to confirm that these royals are really hemophiliacs? Again, I am Dr. Lorraine Marie Item from the Philippines. I am helping you today to early recognize the symptoms of hemophilia and further work up these patients to have an immediate diagnosis and prompt treatment. I think you, as our young colleagues, medical students, and freshly graduates, are really key players in the diagnosis and early management of hemophilia patients. So I think you can recognize this photo. This is a representation of a clot in a vessel wall. So a clot is composed of platelets, coagulation and anticoagulation proteins, and the indivisible system that dissolves or degrades the clot, which is the fibrinolytic system. These are the major components of hemostasis, which is an active process that clots blood in areas of blood vessel injury, simultaneously limiting the clot size only to the areas of injury. Okay, so this slide will summarize the events during hemostasis. So after vascular injury, the immediate vessel response of the body is vasoconstriction. This will be followed by platelet activation mediated by the exposure of the collagen to the surface of the platelet. Platelet activation will also allow platelet aggregation. With the help of von Willebrand factor and the fibrinogen, it will form the platelet plug. So it is said that the platelet plug is a temporary or short-lived patch in the vessel wall, sufficient enough to stop minor bleeding. So vasoconstriction up to platelet activation and platelet plug will be the primary hemostasis. It will be followed by the second phase, which involves the coagulation cascade. So the tissue factor will be exposed to the vessel injury, triggering the response of the cascade, which is the end result will be thrombin's conversion of the fibrinogen to fibrin. Fibrin will form fibrin strands, which will be the one to trap the blood or red blood to create the blood clot. So this will be secondary hemostasis. Hemostasis will not be complete without clot degradation, and this will not be possible without the help of plasmin. Okay? Zooming in to our main interest today. This diagram shows us the coagulation cascade, which is a systemic manner of initiating activation of the next clotting factor by the previously activated clotting factor. So during vascular injury, the tissue factor generates an over 1,000-fold increase of factor 7. So this results in the amplification of the process to give a burst of clotting where it is physiologically needed. So factor 7 will activate factor 10 through factor 9. However, the activated factor 9 must always form a complex with factor 8. Okay? So to generate factor 10 and subsequently create or form the thrombin and fibrin. So if you take a look at that process and system, any deficiency in proteins, any disturbance in the major factors of hemostasis will cause or produce bleeding. Okay, so with all these processes, how will we be able to diagnose bleeding disorders? How will we be able to diagnose specifically hemophilia? So let's take a look with the case. Okay, so the case is an 8-year-old male. So this is actually a case of a relatively popular person in history. So he is an 8-year-old male complaining of hematoma on right thigh after falling from a chair. What do you think is the next best thing to do? Okay. Are we ready to stop the poll? Okay. So 97% answered do a complete physical examination and history. Actually, I preempted the answer by clicking on the next slide. I am sorry. So only 3% answered request for complete blood count. Okay, so I'm happy that you answered letter A because, as you know, the approach to diagnosis to any patient should always include um, or should always be started with careful history taking and thorough physical examination. So it is said that a good, detailed, and comprehensive history and physical examination are the best predictors of a bleeding problem. So often, this history and PE, physical examination, will make a good documentation of the presence or absence of any hemostatic disorder, possibly with 90% accuracy. It is journals already mentioned that it is not just me that said that. Okay, so that is how important physical examination and history is. Okay, so not only that, a proper history and physical examination is also vital because the information gathered will ultimately guide the direction and extent of the laboratory evaluation. Okay, and this will also help in determining, anticipating the possible complications of bleed. And so we can prevent and manage these possible complications. Also, um, again, as I mentioned earlier, um, you are the ones who will be the first lines in the diagnosis, but also you will be the one who will play as important factors in the management, efficient management, and prompt management of these patients. Okay, so um, uh, okay, I will try to start my video and open my camera. Okay, so let's proceed with step one. Step one will include your questions should be asked relating to the type and sites of bleeding. Okay, whether it involves the skin, for example, petechiae, ecchymosis, purpura, or is it from mucous membranes like gingival bleeding, gingival hemorrhage, epistaxis, gum bleeding, hematuria, menorrhagia or menstruation can be forms of mucous membrane bleeding. This bleeding, the ones I mentioned, will most likely point to a platelet or vascular problem. While if the bleeding is coming from the deep tissue, the joints, and the muscles, this will oftentimes suggest coagulation factor defect. Okay. Also, questions should be asked regarding how the bleed occur. Is it spontaneous? Is it does it follow trauma? Because any easy bruisability or excessive bleeding after injury will tell us that the bleeding may probably an inherited bleeding problem or from an inherited bleeding disorder. The duration of bleeding should be also taken because this would indicate whether the symptoms of the bleed have been lifelong or since childhood or of um, recent onset. Okay. Also, the bleeding history of the patient, especially if or they are already adolescent or they are already adults, childhood recurrent epistaxis, umbilical stump bleeding or bleeding from the umbilicus during the newborn period, bleeding after circumcision, tooth extraction, vaccination, as well as poor wound healing will help us to answer questions regarding um, the probability if this is inherited or is this temporary or acquired. Okay. Next, any history of transfusion will suggest the severity of bleeding, whether it is platelet concentrate that was transfused, red blood cells that was transfused, or plasma. Okay. Blood component transfusion will tell us significant information. Last but not the least is a careful family history. Okay, so any family history of abnormal bleeding in both parents, grandparents, uncles, aunts, siblings, or cousins, as well as any history of consanguineous marriage will be important. Okay, so back to our case. So our patient on further history was noted with bleeding from the umbilicus at 1 month old. Sorry, at 1 month old, that's at 1 month old. His uncle and two cousins were diagnosed with hemophilia. Which of the following best describes hematoma? So is it A? Is it a 1 to 3 millimeter red, non-blanching macular lesions caused by intradermal capillary bleeding? Is it B? Larger in size, typically raised lesions resulting from bleeding within the skin? Or is it more than 1 centimeter and deeper in the dermal layers of the skin? Or D? Is it more is it a bigger bleeding between tissue planes? Okay, you can answer now. Okay. Okay. 38% answered letter A, 19% answered B, 24% answered C, and 19% D. Oh, it is distributed. Okay, but most of you answered letter A. Remember, the question is, what is hematoma? What best describes hematoma? Okay, so the history is followed by a careful and thorough physical examination. So to assess the severity and the location of bleeding, and also to evaluate if the bleeding is part of a systemic illness, a local anatomical defect, or is this a hemostatic disorder. Okay, if your patient has lymphadenopathies already or have hepatomegaly, splenomegaly, you should always consider a systemic illness. Okay. Also, from the clinical assessment you made during the physical examination, you can be you will be able to differentiate and categorize the cause of bleeding, most especially limit it from a platelet defect to a coagulation defect. Small bruises like petechiae are common in platelet defect or deficiencies. Most commonly, we see petechiae among patients who have thrombocytopenia. Although those who have coagulation problems will also manifest with petechiae, most commonly, it is among patients who have platelet deficiencies. Ecchymosis can be manifested by both disorders. However, ecchymosis will be larger or are expected to be larger among patients who have coagulation defect or deficiency. Excessive bleeding after minor trauma or cuts can be profuse in platelet defects and deficiencies. So if you will already notice those bleeding coming from the skin and mucous membranes are more commonly associated with a platelet defect or disorder. Whereas those who have bleeding from soft tissues and joints will be common among coagulation defect patients or those patients who have coagulation defects or deficiencies. Also, the difference between the two disorders or source of bleeding is that after or during surgery, those patients who have a platelet deficiency, their bleeding is usually immediate. Whereas those who have coagulation defect, they have delayed bleeding. Remember what we discussed during the hemostasis part, that there is a primary hemostasis which create the temporary patch or plug that will control minor bleeding. So for patients who undergo surgery, they have that primary hemostasis. Okay. Also, those patients who have coagulation defect can really form clot. However, the formation or the formed clot that they create will be abnormal, meaning to say it is not robust, it is not sturdy, and it will not be permanent. Okay, so it is not firm. Okay, so easily destroyed. The clot that is being formed by those who have coagulation problems is abnormal and not robust. Okay. Okay, so pertaining to the question we posted, the letter A option is the characteristic of petechiae. Okay, so a petechiae is like this. So right upper and center lesion. Okay, they are lesions described as 1 to 3 millimeter, red, non-blanching, macular lesions caused by intradermal capillary bleeding. So as we mentioned earlier, the primary cause or most common cause are of platelet deficiency or defect. The letter B description is a description pertaining to a purpura. They are more than 3 millimeter in size, typically raised, like your Hinox-Schönlein purpura or HSP, resulting from bleeding within the skin. Ecchymosis looks like a coalesced purpura or petechiae, so they are larger and occur deeper in the dermal layers of the skin. Whereas, if you have hematoma, that is the letter D description, and the correct answer, they are larger, whether they have discoloration or they are skin colored, they are larger in size, and they are bleeding between tissue planes. Okay? So, having said that, we should bear in mind that we should be able to identify and recognize, to describe what kind of bleeding we see or we saw, which our patient manifested, most especially if the lesions are on the cutaneous area or on the skin. Okay? Okay, now we proceed again and go back to our case. Okay, so with the present history, past history of the patient, at this point, I think you already have a diagnosis in mind. Am I right? Yes? Yes? So, if the patient and the hospital has all the resources, what laboratories will you request? You can pick as many as you think is necessary. Okay, you can answer now. Okay, okay. So a lot of you mostly answered letter D. Ah, wow. You already know the diagnosis of the patient and the workup to request. Okay, so most of you answered letter D, 80%. And next is PT, letter C, followed by CBC and peripheral blood smear. Okay, what if your patient, same patient, this patient, what if different case scenario? The patient lives in a far-flung community and asks you to prioritize only a single laboratory test. You can choose only one. What will it be? Wow. You group of medical students really make me happy. So a lot of you answered letter D. Only 6% so answered A, B, and C. So I think in your minds, you are thinking that the diagnostic and confirmatory or the best screening test at this point is the activated partial thromboplastin time. Okay. So careful and thorough history and physical examination allows us to adopt a sensible plan for laboratory investigation. Okay, so if upon your history there is no bleeding, and if upon your physical examination there are no signs of bleeding, therefore the laboratory tests are not recommended at that point in time. Okay, again, if you do not elicit bleeding on your PE, on your history, um, laboratory tests for bleeding disorders are not warranted at that point in time, or will not be warranted at that point in time. Okay, so the ideal screening test for bleeding disorders includes your blood count or your complete blood count with your platelet count, as well as the blood film or your peripheral blood smear. They are PBS or peripheral blood smear are oftentimes or is oftentimes ignored or forgotten to be requested. PBS or smear will tell us a lot of things. So with a simple examination of your smear, you can tell whether the patient will have anemia, leukemia. You can manually count for platelets by examination of your smear. And your CBC or blood count will tell you the most important part is your platelet count. So thrombocytopenia is the most common cause of bleeding problem among children. So a level of 50,000 cubic meter is said to have no will not produce signs of bleeding. Only those who have less than 50,000. So that is according to researches and observations of different journals. Activated partial thromboplastin time is a test for your intrinsic factor, including your factors 8 and factor 9. Prothrombin time will be a test for your extrinsic factor, factors 1, 2, 5, 7, and 10. Also, those hospitals, they add thrombin time. Hospitals or institutions who are equipped with this examination. Thrombin time will tell us the um, the time, or will detect the time of fibrin generation or fibrin formation. Lastly, bleeding time is the least reliable of all these screening tests, okay? Because although this has been used for over centuries, for a long time, this bleeding test is poorly reproducible. We cannot standardize the test. The simple advantage of this is that it is easy to perform. However, the result is not often reliable. Okay, so you should also note that the results or normal values for your PTT and PT will be dependent from the laboratory because it varies from laboratory to laboratory. But most of the literature and most of hematologists will consider an abnormal result only if the result is 1.5 times or 2 times the control, or if that difference of the result is 30 seconds from the upper limit of the normal or of the control. Okay? Again, the normal values is dependent on the laboratory or the machine you used, and the interpretation of your result, of your PT and PTT result, will be dependent on the difference of the value from the upper range of the normal. Okay, I hope that is clear. Okay, so it is very important that you you know that the aim of the screening test is to reveal broadly the source of the problem and accordingly request for further investigation or request for further laboratory tests. This table will just show you a summary of results or the summary of combination of results. Okay, for example, if you have an isolated prolonged prothrombin time, this will often suggest factor 7 deficiency. However, some patients who are taking oral anticoagulation therapy will also have prolonged prothrombin time. Whereas, if you have prolonged or isolated prolonged activated prothromboplastin time, you should always consider the most common bleeding disorder, and that is factor 8 and factor 9 deficiency. Although, you should always put at the back of your mind that this can be probably also factor 6, factor 12 deficiency, and also a von Willebrand disease. If you have both coagulation parameters prolonged, the deficiency could be of factors 5, 10, and 2. But prolonged PT and PTT are most commonly manifested by patients who have vitamin K deficiency, most especially among infants, and those who have liver disease. Okay? So, if you have prolonged coagulation parameters and also prolonged thrombin time, you should consider a possibility that this may be probably a fibrinogen deficiency. Okay? And if you have prolonged bleeding time or abnormal result of platelet function analysis, you should consider platelet function defect or von Willebrand disease. Okay, I hope you get that. So let's get back to our case. So the complete blood count showed normal results. Platelet count is 350,000 cubic millimeter. The peripheral blood smear is normal. Prothrombin time was 15 seconds. Activated partial thromboplastin time was 65 seconds. What will you do? A. Refer to a hematologist. B. Request for factor 8 and 9 activity level. Transfuse fresh frozen plasma. Or D. Apply ice, compress, and elevate the extremity. Okay, you can answer now. At this point, I know you are highly considering factor 8 and factor 9 deficiency, right? I think I'm correct. Okay. Okay. So, half of you answered to apply ice, compress, and elevate the extremity. So, half of you opt to manage the patient and administer adjunctive and supportive management. Okay, so I think with this given lab test, you can already consider doing all these options. Okay, you can refer the patient to a hematologist and also request for assays. Because if you in the Philippines uh, we do not have readily available replacement for factors, so oftentimes we use fresh frozen plasma. And so if you have prolonged PTT, I think it is prudent to manage the patient already. And also, it is also appropriate to give the necessary adjunctive or supportive treatment. That is my opinion. Okay, so step 4. In step 4, in requesting for specialized tests or proceeding to specialized investigation, we should bear in mind that the tests for hemostasis are not only numerous, but also they are expensive. So specialized laboratory tests should only be directed by the initial impression or by the initial clinical impression, your consideration, your initial diagnosis of the patient, as well as the results of the screening test, of the baseline screening test. So, because if you will not consider your initial impression and your baseline screening, a lot of time, money, and effort will be wasted in proceeding with this specialized investigation. So, in step 4, in proceeding with step 4, I think the this step or the request and the move to do this test should be with the guidance of a hematologist. So specialized investigation or specialized tests like your mixing studies, coagulation factor assays are used to confirm um, already hemophilia. Platelet aggregation studies is used to confirm platelet qualitative defects, and also these are used as investigations for von Willebrand disease. Okay, so if you have a patient who have whose bleeding is consistent with a coagulation defect, whose history and physical examination is consistent with the coagulation defect, plus you have a normal smear, normal complete blood count, normal prothrombin time, and what left you is a prolonged PTT or activated prothromboplastin time. At this point, you can already consider hemophilia. And the request for factor activity level will just help you confirm the diagnosis, establish the hemophilia type, and assess the severity of hemophilia. Okay, so at this point, the next slides will just give you a brief background on hemophilia, its initial presentation, and the laboratory tests available uh, during this time. Okay, so hemophilia is not only the most common serious congenital coagulation deficiency, it is also the most common coagulation deficiency with high treatment cost. So it is an X-linked recessive disorder, and approximately 1 in 5,000 live male births will be affected. Some female carriers will have a sufficient reduction in factor activity level that will cause mild bleeding episodes. So this is caused by lionization of the X chromosome or the inactivation of your X chromosome. So that is the reason why some of the female carriers will manifest with minor bleeding. Also, although this disease is common or popular among European royal blood families, there is no racial predilection. And 1/3 of the patients who are diagnosed have no family history, meaning the mutation may be spontaneous and sporadic. Okay? Most common type of hemophilia is hemophilia A or factor VIII deficiency. Okay. So as I mentioned earlier, hemophilia is an X-linked recessive disorder or disease, wherein if the father is a hemophiliac, okay, all his daughters will inherit his altered copy of the X chromosome or altered gene. So all daughters will inherit the altered or abnormal X chromosome. And none of the sons will be affected because what they will inherit is the X chromosome from their mother. Whereas if the mother is a carrier, okay, so carriers have one normal and one altered gene. They have a 50% chance of passing the altered gene onto each child. So boys who inherit the altered gene from their mother will have hemophilia, and girls who inherit the altered gene from their mother are carriers. So if you notice, although the British family is a descendant of Queen Victoria, no one from the British family was or is affected with hemophilia because Queen, Queen, King Edward, King Edward did not inherit the X chromosome from Queen Victoria, and so he has no abnormal gene to pass through his descendants. And Prince Philip, although Alice is his great great grandmother, the his ancestors or his mother and his grandmother are not carriers. So they were not able to inherit the abnormal gene and produce offsprings with hemophilia. Okay, so there is also a third type of hemophilia. The least common is factor 11 deficiency or hemophilia C. So this is an incomplete autosomal recessive disorder wherein only those homozygous patients will manifest with bleeding manifestation or will have bleeding manifestation. I would like to reiterate these following slides because for those who will be dealing with the pediatric population in the future or those who want to be pediatricians in the future, this is important, okay? So the clinical presentation, manifestations, initial signs and symptoms of hemophilia A and B are similar. And also, both factors cannot be passed through the placenta. Hence, a newborn or a fetus can have bleeding manifestations. And the most common or 1 to 2% of those patients will manifest with intracranial hemorrhage at birth or during the fetal stage. And so if the family has already an information that they have history of hemophilia, it is important that prevention of bleeding during delivery is noted. So use of forceps, vacuum delivery should be prevented. Okay. So as the child grows older, as the child learns to crawl and walk, different initial presentation will be noted. So that will be associated with their start of being mobile. Okay, so these patients with hemophilia will initially present with easy bruising, intramuscular hematomas, and hemarthrosis. The most common and earliest location of joint bleeding among infants is at the ankle in relation to the start of the child learning how to walk or learning how to cruise. Okay. For those patients, on the other hand, who have no family history of hemophilia, the diagnosis is made during situations after circumcision, after dental extraction, after vaccination. Because these procedures, most especially circumcision and dental extraction, are invasive procedures that somehow challenge the hemostatic or hemostasis of the body. Okay, so at one glance, you can already remember, at one glance of this slide, you can already associate the age of the patient and the possible initial presentation of the patient who have hemophilia. Okay, so I would like to briefly discuss the most common and unique presentations of bleeding in hemophilia. So, it is said to be that hemarthrosis or joint bleeding is the hallmark of a hemophilic bleeding. So, again, ankle is the earliest joint involved. And comparing with those younger children who are unable to verbalize initial pain, initial symptom, adults and older children are frequently able to recognize hemorrhage or bleeding even without the physical finding of bleeding or of hemarthrosis, because earlier in their symptom they will already feel warmth and tingling sensation on the involved joint. And true enough, after that tingling sensation, after 1 day, patients will have increasing pain on that location, followed by decrease in motion because of the pain. There will be limitation of movement. And so, other characteristic of hemarthrosis includes your pain, inflammation, swelling or inflation, warmth on the location, and motion restriction. So, another form of bleeding is intramuscular hematoma. This is said to be 10 to 25% of hemorrhagic episodes. So, this is a major cause of disability among patients and usually originates from trauma. Although spontaneous intramuscular hematoma may happen as well as secondary to emotional stress. Again, patients may have a vague sensation of pain during or discomfort during movement, and then will be followed by swelling or inflation on the area. So if the hematoma already is noticeable, patient will have protective muscle spasm and restriction of joint, and then followed by pain. And lastly, iliopsoas bleed. So this is said to be the most life-threatening or one of the most life-threatening bleeding, because patients may have a lot of volume of blood retroperitoneally. So patients will have vague symptoms of lower abdominal or upper thigh discomfort, characteristic gait, hip is flexed and inwardly rotated, and they are unable to extend the hip. So it looks like they have acute appendicitis. So they are the manifestation, the visual appearance of these patients with iliopsoas bleed looks like a patient who has acute appendicitis also. So other forms of bleeding include CNS bleed, GI and GU bleed or genitourinary bleed as manifested by hematuria. So again, for laboratory evaluation, you have prolonged partial thromboplastin time. Sometimes for severe patients, for those patients who have severe hemophilia, the level is 2 to 3 times the upper limit of the normal range. Okay. Also, as a form of confirmatory, those who have less than 40% factor activity level of factor 8 will mean they have hemophilia A, and if it's factor 9, it's hemophilia B. So factor levels will also give us a rough guide for the patient's expected rate of occurrence of bleeding episodes. For example, if the initial or upon diagnosis, the level of factor of patient is 1%, he is categorized as severe hemophilia. So his bleeding will most likely be spontaneous and predominantly involves the joints and muscles. Whereas, if the level is between 1 to 5%, they are classified as moderate hemophilia. and their bleeding is occasional and spontaneous. Severe bleeding will be noticeable with trauma and surgery. Lastly, if the patient has 5 to 40% upon diagnosis, they are all only mild hemophilia. So severe bleeding will be manifested during major trauma or surgery. Okay. Next is mixing studies. So not all institutions have this laboratory test. It is not readily available. But mixing studies is done by mixing the patient's plasma with a normal plasma with 100% factor activity level. So after they are mixed, if the clotting time normalized or correct, it means that the patient has factor deficiency. If it won't correct, probably the patient has a the patient may be having an inhibitor. Okay? So let's go back to our case. So our case is an 8-year-old male who complained of hematoma on right thigh after falling from a chair. On further history, so patient was noted with bleeding stump at 1 month old. His uncle is Prince Friedrich of Rhine, who died because of intracranial bleed at 3 years old. His cousins are Prince Waldemar of Russia or Prussia, who died during the war because of the lack of blood transfusion facilities. And his another cousin, Prince Heinrich of Prussia, died at 4 years old, again because of intracranial bleed. Our patient was not able to do at that time factor activity level. At that time, the only available test is clotting time. So we can say that the patient has prolonged clotting time at this time. Obviously, I just made up the CBC result. I just made up the PT and PTT result of the patient. So our patient is the son of the last Tsar of Russia, Alexei of Russia. So he suffered hemophilia during his entire lifetime. It was said, according to history, that his disease greatly affected the ruling of his father as the last Tsar, prompting the Russian Revolution. Actually, because of his mother's desperation of his illness of hemophilia, he sought the help and spiritual advice of Rasputin, further aggravating the revolution at that time and further aggravating the revolutionaries, making them murder the whole family of the last Tsar of Russia. So in 2007, only in 2007, the remains of Alexei was found. And this was a large factor to settle the gap of medical history and solve the mystery of the hemophilia that runs along or within the royal family. So in 2007, genomic DNA extraction from bone fragments of Alexei and his mother, Sharina, the direct descendant of Queen Victoria, showed substitution in one of the two splicing sites at exon 4 from the F9 gene. This mutation is the cause of hemophilia B that traumatized the whole European royal family. So Alexei was the key to solving that mystery, that hemophilia B and not A was the predominant disease among the royal family members who suffered bleeding at that time. So that genetic testing is not only for dead affected individuals. Genetic testing is used also as prenatal testing. So this is performed by amniocentesis, chorionic villus biopsy, fetal blood sampling. So the gene is located near the terminus of the long arm of the X chromosome. So the most common mutation for or among hemophilia A is inversion, whereas among hemophilia B, it's missense point mutation. So the management will be discussed in detail later, but I just want to show you these slides regarding prevention and some adjunctive management or supportive management which you can do. So with that, I will end my presentation with the quote from The Crown: "To do nothing is the best course of action, but history was not made by those who did nothing." Again, in my experience, there are many patients who are diagnosed only at the time they have severe, life-threatening, and complicated bleeding episodes, who had prior history of bleeding. So it is important that you know the initial presentation or the probable presentations of patients with hemophilia in order for you to recognize them and request further diagnostic workup for definitive diagnosis. Thank you, and these are my references.
Thank you very much, Dr. Lorraine, for such comprehensive lecture about the diagnosis of hemophilia. And now we are moving to the second session of the lecture by Prof. Dr. Hamidah Alias. She graduated MD from National University of Malaysia, and she spent her trainings of the hemato-oncologist at University Children's Hospital Zurich and Sir James Pain's Institute of Child Health at Newcastle upon Tyne. She now works as a consultant pediatric hemato-oncologist at Faculty of Medicine, the National University of Malaysia, UKM Medical Center. To Prof. Hamidah Alias, the stage is now yours.
Thank you very much for the kind introduction, Jeremy. Good afternoon, ladies and gentlemen. I would like to thank the organizing committee of AMSA for the kind invitation to speak at today's webinar. I now shall share my screen, and yes. Does it appear, Jeremy?
Yes, it's full screen.
Yeah.
You may proceed.
Yeah. Right. So this is the outline of my talk today. I will also off my video to ensure that the bandwidth is okay. I'll do that in a minute. And I think I can skip the introduction because the brief comprehensive overview on hemophilia has been presented by Dr. Lorraine. So I will focus on the treatment options toward hemophilia in pediatric populations, including the reason and rationale of hemophilia treatment in this special group of children of patients. Next, I will speak on home therapy and things that parents and caretakers should know about hemophilia management. And subsequently, I will be touching on role of medical students and fresh graduate clinicians in managing hemophilia. Last but not least, I will present a case presentation to share with the whole of the medical students that are present today, and how that we manage a quite tricky and challenging case. So perhaps I can skip some of the initial slides, because as I mentioned, it has been comprehensively covered by Dr. Lorraine during her talk. Just to mention to you that in children, early symptoms of joint bleeds in children at a very young age are a key indicator of severe hemophilia. As you understand, there are different severity of hemophilia, and joint bleeds in children would always indicate that the child has severe hemophilia. This slide shows the 4 important aspects of diagnosis in hemophilia. It's just summarizing what Dr. Lorraine has mentioned. So the assessment of family history, in which that 2/3 of the cases would have a family history, while 1/3 of the cases do not have a positive family history. So this is a group of patients that have presentations with spontaneous mutation, in which that genetic analysis would be helpful in delineating any specific DNA-based mutation. The observance of clinical features, that consists of easy bruising in childhood, spontaneous bleeding of unknown reason, especially in the joint, muscles, and soft tissue, excessive bleeding following trauma or surgery, for instance, circumcision in severe patients. And, as what we mentioned, the laboratory tests of coagulation, in which that hemophilia patients have normal PT, prolonged APTT, and these conditions is confirmed by specific factor measurements of factor 8 and factor 9. So every bleed matters. Even a single bleed may lead to life-threatening hemorrhage or permanent joint damage. As been mentioned by Lorraine, the hallmark or the majority of hemophilia patients would present with hematrosis, about 70 to 80% of them. So a joint bleed is the most common type of bleeding, in them, and it most commonly occur in the knee, elbow, and ankle, and if often, evident from early childhood itself. Next, muscle bleed is the second most common sites of bleeding, especially involving the deep compartment muscles. So complications like compartment syndrome could occur in them, and this is again one of the life-threatening condition which cause patients, to succumb, could cause patients to succumb from the disease itself if it is not promptly treated. The mucous membrane bleeds, more often in those who have less severe hemophilia, but some of them could cause, in occasion, they could cause a major bleeds. They might be proceeding to major bleeds from profuse, bleeding from the sides of the mucous membrane itself. And it has been mentioned earlier, intracranial bleed is quite rare. It is uncommon, but it is the common cause of death, among among the hemophilia patients. So it is very important, when especially you are at the centers that do not have, adequate resources, that do not have, enough consultants, specialists, or experienced medical officers. So with these informations and knowledge throughout, your study years and experience, your clinical experience during the clinical years, and, problem solving discussions, case-based discussions. So this is one of the important, clinical manifestations that needed to be taken into consideration when you are, when you come across, a child or children with this kind of presentation. So as mentioned, hematrosis is, one of the, is the hallmark and the major presentations of children with hemophilia, or even the older patients with hemophilia. The problem is, with recurrent hematrosis, because this recurrent hematrosis would cause progressive joint deformity. And this happened, from the accumulations of blood in the joint space itself, in combinations with the recurrent and persistent synovial inflammation. So these two conditions, would cause patient to have the cartilage damage, and the affected synovium, okay, will be thickened and making it more susceptible to subsequent bleeding. So, i.e., a target joint. So this target joint would have, a recurrent problems of bleeding, hematrosis, and these are the one that, if you don't control adequately, it will cause a progressive joint deformity, and it could cause a permanent disability. So, and this is an example of a patient who have intracranial hemorrhage, and this could occur spontaneous or due to trauma. And as mentioned, this can cause a significant long-term disability, morbidity, and mortality. So moving forward, okay, I would like to I would like to present the key aspects of treatment options toward hemophilia in pediatric populations, including the reason and rationale of hemophilia treatment. The treatment goals for hemophilia patients are as follows. So one is to protect from bleeding. As much as possible, you would need to achieve a zero bleed condition and sustain this zero bleed condition to protect patients from having the complications, especially the joint and the muscles, because these are the target organ that, most of patients will be presenting to you if they have the severe manifestations of hemophilia. Then next, you would aim to reduce pain and the joint and the muscle damage. And as much as possible, you would, try to help the patient to lead a near normal or normal life and have a normal functions of the joint itself. Right? And all these conditions would contribute to improve overall health and quality of life of the patient. So this is not being achieved like overnight process, but this is a consistent and adherence to the treatment itself would be able to, to achieve, the treatment goals of treatment for the hemophilia patients. So next, this you can find, a World Federation Hemophilia guidelines for the management of hemophilia, which was recently published in 2020. And this is the third edition and the latest edition of management guide for the hemophilia. This evidence-based guideline offer practical recommendations on the diagnosis, general management, and also the management of complications of musculoskeletal issues, inhibitors, and also transfusions transmitted infection. Ideally speaking, right? I stressed here, ideally speaking, right? Patient should receive, a comprehensive hemophilia care provided by multidisciplinary expert and experienced teams under the umbrella of Hemophilia Comprehensive Care Center and Hemophilia Treatment Center as a network, because these centers are responsible for the management of the diagnosis, the treatment, and also the management of hemophilia-related conditions and complications, comorbidities, and it should encompass a family-centered care. So we understand that, different country, different centers within the country itself might have, a different strategy and approach towards treatment of hemophilia. So it has to be practical and, adapting towards what your country, what the treatment centers can offer to the patient. Right? So ideally speaking, in many centers, with established centers, these are the treatment, or the management capacity and capability that they can offer to hemophilia patients. So when you talk about multidisciplinary experts, ideally speaking, it should consist of all these experts, focusing on the patient management. A hematologist, patient management specialist, because pain is one of the major issue in hemophilia patients when they have bleeding in the joint, in the soft tissue, in the muscles. Okay, you should have a specialized nurse that being trained in hemophilia. And of course, the family and friends supports as well, the physical therapists, the dentists, primary care physicians. You might be one of, the person in this, bubble itself when, you are stations in different parts of the tier of the healthcare facility in your country. All right, a social worker also would have, a major role in managing the patients, because if the patient is in the rural area or some radius that it is not, accessible to the center of treatment, this is where that, the help from them is very important. Okay. The pharmacists, in dispensing and delivering medication, the psychologists in, managing the emotional and psychological issue of the patients and family as well. And you have heard that Dr. Lorraine has presented that, it can be triggered with some emotional issues and emotional problem. The orthopedic surgeons, with regards to, combined or management of joint issues, or joint complications of the patient. So those are, the important thing. And, before I proceed, I would like to mention that, I'm going to highlight 5 important management aspects for this presentation itself. For the second part is the second point is the procurement of the missing clothing factors, because, sustained availability of, coagulation factor concentrates is sufficient quantities is strongly correlated with better outcomes for people with hemophilia. So, the countries must establish a rigorous national tender system. What I meant with tender systems is that how that the country budget, the purchase of factor concentrates in your country. Again, that different country would have a different system or the tier of, how that the system manage the patient. You might be, receiving a direct, supply of the factor concentrates or the medications, without needing to put in a lot of money, to get the medications. But, some country would need to prepare the whole lot of budget, to get the medications itself. So it is very important to ensure that people with hemophilia have reliable access and effective, clothing factor concentrates. Hence, they have a betterment of treatment received for the disease itself, right? And next, you would need to deliver current standard treatment for the patient. Of course, that, when we say the standard of care and the current standard treatment for the patient, in some part of the world, all right, in a low-income country or even in a lower middle-income country, would not be able to afford this, would not be able to comply to the standard of care. But it would be good to know what is the standard of care for all patients, so that, when you are projecting your care, not to say career, when you are projecting what you might be experiencing in the next 5 years or 10 years, then you know that, these are the things that it is important to know, to be aware about the standard of care for hemophilia patients, because these are the significant, movement that make a lot of difference to the quality of life, to the overall outcome of management of the patients. So the standard of care for patients, this is for severe hemophilia patients, is the prophylaxis. Prophylaxis with CFCs, I abbreviate it, but as I mentioned to you, you understand that this is a clothing factor concentrates. So clothing factor concentrates refer to factor 8 or factor 9, depending on what type of hemophilia they have, all right? Or it could be other hemostatic products, to prevent the bleeding, depending on the resources of your country and how much that, your treatment center permits, okay, the availability of factor concentrates. But the key point is that the standard of care is for you to prescribe prophylaxis, prophylaxis CFC rather than on-demand treatment. I will cover on the demand treatment, which I believe, some of you have, session knowledge that, this is actually what it meant with on-demand treatment. Okay, and prophylaxis should be started early in life before the patient is 3 years old to prevent the major complications that includes the musculoskeletal and also muscle bleed. So joint, muscle, soft tissue. Okay, so these are the three main, organ or anatomy part that the hemophilia could have complications, and cause a significant morbidity. We're not talking about the mortality, but the morbidity that the patient could experience in long term, and they are still alive, from the conditions of the hemophilia. So this is what you want to minimize, the comorbidity, and patient would have, a good quality, overall good quality of life, and lead the, the life very near to the non-hemophiliac patients. Okay, so you could be aware by now that the wide range of product classes and types used in use around the world, just reflecting that the evolutions of hemophilia treatment products and the variations in local healthcare resources and capacity. So Malaysia might be having a different strategy because of the resources and capacity. But in Taiwan, in India, you might have better resources and capacity, depending on how, how established, the center for the hemophilia treatment has been set up, in our different centers. But bear in mind that product selection should evaluate key requirements, including the safety of the product, the quality of it, whether it is effective, the purity of it, and the viral inactivations, because you also do not want patients to have side effect, from the treatment as much as possible. You do not want patients to have side effect from your treatment that you prescribe. All right. So if a patients have, hepatitis B or hepatitis C, that, the chronic active hepatitis is not something that helpful in long term. So they would be needing, another treatment regime for the side effect that they gotten, from the treatment itself. So bear in mind that, this product selections is very important to take into considerations all these factors. Okay. And yes, this slide shows you the types of hemostatic agents that are available in the market. And as I mentioned to you, the clotting factor concentrates, is the standard of care at present, for the severe hemophilia, and also some of the patients with moderate hemophilia that experience, a very frequent or similar phenotypic, bleeding manifestations like the severe hemophilia. So I will further elaborate this in the subsequent slide, because, they have two preparations of the CFC. Bypassing agents is normally used, for patients who develop alloantibodies or the inhibitors. Okay, they are not responding to your treatment, and now they develop inhibitors that basically neutralize, the antibody. So you need to use a bypassing agent. Other plasma product, the cryoprecipitate and the FFP, like has been mentioned by the first speaker, and other pharmacological options, like DDAVP and tranexamic acid. And, a recent, advance in the treatment of hemophilia is the non-factor replacement therapies. So this is a non-factor replacement. It is not the factor concentrate, but then, it is targeting, all right, the intrinsic cascade somewhere, along the line of the intrinsic cascade, okay, to replace it and, to help patient to minimize or achieving, a zero bleed. And this factor, mimetic, emicizumab, is already in trial and already being used by some of the developed countries. And, I believe, some countries also is having access to these medication or non-factor replacement therapies. And another inhibitors that, so far it is not often been used, but, to let you know that it is available in the market. Right, so this cartoon just tells you the changes in the treatment landscape of hemophilia from the 1950s, up to present. So if you look here in the 1950s to 1960s, the blood products has been heavily used and evolving to, in evolution in the subsequent decade itself, plasma-derived clotting factors has started to be, innovated, and, from very regular usage of the blood product, now you're talking about episodic therapy. So, or you're talking about on-demand therapy here. And more recently, the recombinant clotting factors are in the market, and the bypassing agents, as I mentioned to you, and, the most recent, you're talking about, prophylaxis, in the severe hemophilia and some of the moderate hemophilia patients, okay? Right, so, the CFC is the most safe and effective for treating and preventing bleeds. And there are two main types of CFC that you can find in the market. One is virally inactivated plasma-derived products that is made from plasma donated by human blood donors. And this is from human blood donors. These are just the example of the brand, all right? It is not the generic name, but this is the brand name of the plasma-derived, factor 8. And the other preparations is the recombinant products manufactured using genetically engineered cells and recombinant technology. And again, this is the brand name, but not the generic name. And these CFCs can be available in the standard half-life or extended half-life. When you talk about extended half-life, it means that, the medication could stand, for about 2 to 2.5 days. So, you can sort of, spread the prophylaxis frequency for the patients itself, upon consultations or upon referring the patient to the hematologist in charge, okay, or to the experts who is managing hemophilia in your country. All right, so I have mentioned this. I will not repeat that, okay. And episodic or on-demand therapy should, in the presence, in the in the situations that prophylaxis can be executed, can be given to the patients, the episodic or on-demand therapy should no longer be considered as a long-term treatment option. All right, but of course, there are some limitations in other countries that you are not able to give a prophylaxis, so you might be reverting to episodic or on-demand therapy. Okay, you would need to see the practicability of, the management center of what kind of treatment that you can offer. But of course, you are not just staying at that level, but you have to move forward and try to, very much move forward towards, prescribing prophylaxis, because the overall treatment goal would be achieved, in a better manner. Right, so this is, the as I mentioned to you, it can be administered, a few ways on demand that I have covered to you, and this is only given, when bleeds occur, and prophylaxis, as you are giving these whenever that you have a steady or sufficient supply of the factor concentrates. It's very important that sustainability of supply, would ensure that, the regime of prophylaxis is successful. So before you embark into prophylaxis regime, you really need to discuss, in detail, the feasibility of, applying this regime of treatment. Continuous infusion is mainly used for surgery or treatment of severe bleeds requiring prolonged replacement therapy in order to have a constant steady state factor level. So for instance, a patient is going for major surgery. So you would want to, prescribe these patients with continuous infusion to ensure the background level of the factor concentrates is adequate, to minimize any risk of bleeding from the surgery itself. Okay, so this, as I mentioned previously in my earlier slides, this is used, in patients who have developed alloantibodies or inhibitors, because these alloantibodies, neutralize the function of the infused CFC. And these are the example of bypassing agent that being used, okay, in patients who develop inhibitors towards the CFC. When you talk about cryoprecipitate and FFP, although that we understand that it is not widely used, okay, it is still widely used in countries where they are the only available or affordable treatment options, you must be aware about the quality, the safety, and efficacy of the FFP and cryoprecipitate. So the blood bank, preferably and should have all these mechanics of filtering, mechanics of screening all blood product that it is safe, from a transfusions related infection. All right. And bear in mind that there's no proven advantage for their use over CFC. Although CFC is a very expensive drug, to engage with, but when you talk about, the management of patients, then of course, CFC is over the cryoprecipitate and FFP. I have used, FFP during the time that I cannot get access, towards cannot get access, to CFC. But, when you work harder and you work seriously on the CFC, you might be minimizing the use of FFP or cryoprecipitate in your patient. And the use of cryoprecipitate can only be justified in situation where CFC is not available, and again, because there's no proven advantage for their use over CFC. Right, so next is other pharmacological options like desmopressin or DDAVP and tranexamic acid. So DDAVP may be the treatment of choice for patients with mild to moderate hemophilia A, all right, and it can be used, for children for no more than 1 dose per day if you're prescribing to children, and no more than 3 consecutive days because a patient can develop tachyphylaxis, all right, and risk of other complications. So therefore, okay, we do not recommend it to be used more than 3 consecutive days in children, and it is contraindicated in those who are less than 2 years old because of the margin of the side effect itself, all right. Next is the tranexamic acid. It is used, as adjuvant treatment, particularly in controlling mucocutaneous bleed. So if a patient have, epistaxis or nasal bleed, okay, and some mild gastrointestinal bleeding, okay, just some mild gastrointestinal bleeding, or patient is going for dental surgery and eruption or shading of teeth, you might want to consider prescribing patients with tranexamic acid. And this is for a short period of time, perhaps, 1 or 2 weeks itself. Okay, so moving to the non-factor replacement therapy, okay, just to give, a bit of information about factor VIII mimetic or non-factor replacement in the market. This is pretty recent and the most advanced, non-factor replacement that is available for hemophilia patients. And emicizumab is, the first and only licensed substitution therapy at present. And if you look here, this treatment itself, it is an alternative mode of delivery that could minimize whatever that, the limitations that current CFC therapy does to patient. It's like the IV administrations, because this one you can give it subcut. And the CFC have short half-life, even the extended half-life comes in, but then you must take into consideration the cost for the CFC of extended life, the risk of inhibitor formations, and these non-factor replacement give markedly improved pharmacokinetic profile with a low burden of administration. So patient might be, receiving it up to monthly dosing, and this may increase compliance. But bear in mind that this is a very expensive drug. Even in Malaysia, so far we only give one compassionate basis of this, emicizumab, for our patient. And like what, Dr. Lorraine has mentioned, gene, when you are doing, some gene tests, whole exome sequencing, or some slicing, or, of the gene, then, here where the gene therapy comes in. So several clinical trials in both people with hemophilia A and hemophilia B have demonstrated success with a favorable safety profile. So in near future, perhaps, it's not long from now, maybe that gene therapy can already be applied, in some of the developed countries, and we can learn from them, how do they do gene therapy. All right. Of course, from in the setting of this region of country and our country, we are still looking at the FFP cryoprecipitate. We are struggling, with some of the patients with severe hemophilia that we do not have adequate blood product and those things, you see. But these are the things that we should be thinking, in 5 to 10 years, if we are not be able to think about this, immediately, or, in these immediate few years. All right. So next, I will move, I'll be speaking quickly about the home therapy and things that parents, caretakers should know about hemophilia management. And, hemophilia therapy and self-management is very important because, it increases the compliance and allows people with hemophilia to live relatively normal lives. It cuts, a lot of problems when visiting the hospital often. All right. So it is, it will enable optimal early treatment, and when you can deliver early treatment and the adherence is good, okay, this will result in less pain, less, dysfunctions of the joints and, the long-term disability as well. All right. So it's definitely, it reduces hospitalizations rate, for bleeding complications, following the compliance and adherence, to the treatment. If you are teaching, the parents and the patients very well, they understand, and it have to be very close supervisions, of them, when they are doing home therapy. Bear in mind that you must do a comprehensive patients or caregiver educations and trainings so that they are confident enough to do it and not giving, additional problem or complications, if comparing to the patient receiving treatment in the hospital. Okay, and as I mentioned to you, it have to be closely monitored by the hemophilia care center team, or whatever team that is available in the hospital, okay, in the respective hospital. This is definitely aimed to improve overall quality of life. All right, so the home therapy, you must instill the essentials of basics of home therapy. These are the essentials. Essentials means that the parents must know about it, so that to ensure that it is successful home therapy. It is achievable, it is successful, and hence the patient would have a better quality of life. You need a cooperative patient and mom as well. So if the patient's struggling, keep on crying, you definitely wouldn't be able to do that. All right. So this is important because you're talking about, injection. You're talking about, how that you want to keep to the time of, delivering the factor concentrates. You're talking about how that you are disposing, okay, the needles. So here is a summary that, the parents must be able to recognize bleeds and common complication. They must have, first aid measures at home. They must know how to, do the calculations of the dosage, which, they have been taught by the doctor in charge. They must know, how to properly store, how to properly prepare and administer the CFC itself. They must be confident. So it means that you might be priming the parents to do it in the hospital under observations, before they do it, before they embark, with home therapy. So observe kind of, preparations and procedure being conducted by the parents in the hospital would give, would help and would give confidence to the parents to do it at home. All right. And they must be taught about the access through the central line catheter. So like us, we teach the mother that how to take care of the central venous catheter, the potacat itself, all right, and how the regime of, injecting through the potacat, okay, they must have that skill of injection and how to infuse that. And they must keep a good record keeping. Otherwise, you wouldn't be able to track what's happening at home when the patient comes to follow up. All right. And this is what I've mentioned to you. They would need to have a proper storage and disposable of needles and sharps. So you would need to provide patients, with some of these, equipment, all right, for you to help the parents to store it and not just, throw it in the dustbin. Because you know that, as a medical student, you have been taught that, these are dedicated container for the needles and sharps, otherwise if you lump everything together, who knows that, the HIV, drug addict, would go and collect needles here and there and use, and to infuse, drugs into the vein. And parents must be taught how to handle blood spills. So to have, this home therapy, you must have a product that is safe and easily reconstituted, so that the parents, is not under stress. They are familiar of how to reconstitute the medications, okay, the factor concentrate, and deliver it to their children. And be aware that, they must know about the adjunctive therapy as well. That what, Dr. Lorraine has mentioned to you, the RICE and the P is just, protection. Okay, so it becomes price, and they must know, how the antifibrinolytic, agents would be helpful in certain situations, and pain management is very important. Okay, adhere to, some of the rules of physical activities or PE, and they must know how to do risk navigation. All right. And the fifth point that I would like to present here is the systemic surveillance for inhibitors. Inhibitors, somehow or other would be a problem, and it could develop in patients. It is not a rare condition. The case that I'm going to present it to you is a similar situations to this, point number 5 itself. So you must do inhibitor screening looking at the protocol, and the Haemophilia Center must develop a protocol. All right, you must have, a protocol so that the house officer, the medical officer, the specialist consultants are aware about the protocol, and they can do, immediate reaction. Okay, not reaction, immediate action to a patient who comes to you with a suspected hemophilia condition, or a patient with hemophilia who develop complications and those things. All right, it is not that, you are expected as a fresh graduate to instill factor concentrate, but your job, not to say your job, your task of seeing the patient immediately at ED or at the presentations to the daycare is very important, okay, to activate, the cascade of treating the patient. The earlier, the better the outcome would be. All right, so inhibitor could develop after few factor exposures, okay, ED. And you can detect this when patients experience recurrent bleed despite adequate factor concentrate therapy. And the patient achieve just a lower than expected factor recovery after the CFC replacement therapy. So you can suspect that patient might be developing inhibitors. And here when the patient develop inhibitors, a comprehensive management of inhibitors must be instituted. Okay, you can eradicate inhibitors by immune tolerance induction therapy, in short form is ITI. And if patient experience acute bleed, you must give bypassing agents, during the ITI itself. So this is the basic things about treating patients with inhibitor. All right, and recently, if patients are not responding to this treatment of inhibitors, then you might be considering the non-factor therapy of emicizumab. All right, so when you do all these things, you must do some outcome assessment. Otherwise, you do not know whether you need to modify the treatment for your patient, or you need to do a counseling to the parents and patients, especially the adolescent patient, because we know that adolescent is associated with some form of rebellious, when you're talking about chronic diseases. So you could have a challenge and tricky parts of, adherence, especially in the teenagers group of children. Okay, you wouldn't call them children anymore, but then, they are in the transitions period from the children to the adolescent. So you must have some score that, how that you want to assess, the outcome from the treatment that you deliver to the patient. This is not just talking about hospital-based treatment, but it also includes, home therapy, of the patient. So you must have some form of scoring, system, and you must have some form of how that you rate the annual bleeding itself. So there are many scoring systems that available, but this is one of the scoring system that we use for the Malaysian patients with hemophilia, and we also do have health technology assessment report for the hemophilia patients in Malaysia. And for this one, which I extract it from the World Federations of Hemophilia guideline just now, the 3rd edition, you always would need to know that a disease-related outcome factor, environmental factor, and also the personal factor, the patient's factor itself, okay, to do the overall assessment of outcome. Okay, so this is going to guide you whether your treatment is adequate for the patient. Your treatment is, the patient is doing well with the annual assessment, and you do not need, whether you need to modify the dose, you need to enhance compliance, you need to speak to the parents, revisit on certain aspects of educations with the parents. Okay, do they have any psychological issues? Do they have issues with adherence and some other things? So here where the multidisciplinary experts comes in. Okay, if you remember the flower at the beginning in one of my slides, so those are important. You might be incorporating, only some experts, at the periphery of the flower, but you must be smart enough of how to choose. Okay, the people, the expert in charge, a relevant expert to come and sit down and speak to your patient. Okay, so yes, so those are the those are the important aspects of treatment for hemophilia patient. When it comes to the role of medical students and fresh graduate clinicians, I believe it has been incorporated, and it has, a take-home message has been incorporated during, the sectional presentations of, the treatment options in this patient, and also the home therapy of the patients. Okay, so now I move, I move to case presentation, and this is the patients that in our center that I managed recently a few years ago, and it is, I think, it is good to share with you all. Am I a male newborn? He was born term via spontaneous vaginal delivery with a birth weight of 4.6 kilogram. Antenatal history was uneventful. And the patients experienced right brachial plexus injury secondary to shoulder dystocia because, the patients have a bit of, weight of 4.6, a big boy, a big, baby, all right? So he developed right diaphragmatic paresis and initially required non-invasive ventilation. So he only needed CPAP, but because of increasing respiratory distress, he needed BiPAP for a certain period of time. However, the condition resolved at 2 months old. Right, now we are entering poll question. The following feature or features is or are associated with brachial plexus injury in newborn. You can choose more than one stem or answer. Right, are we ready to show the response? Right, that's great to know that, even it is not covered in this lecture. All right, 94%, answered as paralysis of the ipsilateral arm. 59% answered incomplete motor reflex, and 6% answered normal reflexes in the affected arm. And I would like to respond, to those answered normal reflexes in the affected arm. You would, get a baby who have hyporeflexia in the affected arm. Yes, they get, incomplete motor reflex. They can have paralysis of the ipsilateral arm, and in most circumstances, okay, in a typical brachial plexus injury, the newborn, okay, would have hyporeflexia in the affected arm. It could be normal, but then in a typical presentation, they would have hyporeflexia, okay? Right, at day 3 of life, the baby, MI, developed right cheek hematoma, right periorbital bruises, and also right conjunctival hemorrhage. So if you can see here, this periorbital bruise and also this, quite huge right cheek hematoma. And the conjunctival, we couldn't show it to you. And on the subsequent day, he developed, we observed that, he has left hand bruise at the branula site. So we are entering another poll question. State your differential diagnosis for this condition. And again, you can answer more than one stem. Right, are we ready with the answer? Yes, 11% answered sepsis, majority 78% answered bleeding disorder, 58% answered hematoma secondary to birth injury, and 67% answered vitamin K deficiency. Right, so number 1, 2, and 3 definitely could be your differential diagnosis. Okay, when you go for exam, all right, even though that, it can guide you with the word differential, you must see here that no cyst. Okay, so your differential diagnosis definitely would need more than one answer. All right, so yes, number 1, number 2, and number 3 are correct. I would accept also number 4, vitamin K deficiency, although it is not often and very rare for vitamin K deficiency to present with huge, hematoma and quite extensive bleeding, over the face. They present to you with, umbilical bleeding, and they could be presenting with some form of moderate, which is commoner. But yes, the answer is correct. 1, 2, 3, 4, that, it could be your differential diagnosis. Okay. Right. Next, we are entering another poll question. Select the relevant investigations you would do to arrive to the diagnosis. And your investigations must be guided by your differential diagnosis. And this one, you still can answer more than one option. It is a multiple choice. Right. Do we have the answer? Right. 82% answer for blood count. Good. 85% answer coagulation profile. Good. 38% answer blood culture insensitivity. Good. 38% also answer CRP. Yes, when you're talking about sepsis. Right eye swab culture insensitivity. 13% answer that, and 26% answer liver function test. Okay, so if you go by the most important answer to the least important answer, and in your exam setting, you wouldn't be able to get more than 5 answers. Okay, the most perhaps is 5 answers. I'm not so sure. In different country, the setup would be different. But the thing is that I'm pretty sure that you don't have or 6, 7. But for educational purposes and discussion purposes, I put it number 1 up to number 7. All are correct, except we can discuss about number 4 and number 7. So when you talk about eye swab culture and sensitivity, in these patients who develop, an extensive hematoma and bleeding, okay, this is the least relevant, and some would say it is wrong. Why? When you do swab, you're thinking about GBS, maybe, all right, but not really. You don't talk about GBS when you do eye swab. You're talking about what do you call that? Mycoplasma. You're talking about an infection that you can obtain it from the right eye itself. Okay, the swab itself. So this scenario of illness for the patient so far have not indicated to you that this patient is probably having, like mycoplasma kind of infection. Okay, liver function tests. It is not totally wrong, but these two, number 4 and number 7, would be the least in the list, on the list that will be accepted as a relevant investigations for you at this stage, for you to arrive to the diagnosis. So here, when we speak to arrive to the diagnosis, your full blood count, you want to see the platelet level, all right? Your coagulation profile, your DIVC, this would be helpful, very strongly helpful, that can guide you to the diagnosis itself, okay? So that's important. I'm not saying liver function test is wrong, but what I'm trying to say is that you go by the priority of your relevant investigations that you want to do for the patient. Okay, right. So these are the investigations results of the patients. The full blood count was normal. The blood culture have no growth. The CRP has not raised, was not raised. The ultrasound, have revealed that it was an hematoma, and the patient has isolated prolonged, APTT. The mixing test was positive with the APTT of 93.3 corrected with the mixing test, and the factor VIII assay was less than 1%. It's actually not detected, and the diagnosis was a severe hemophilia A. So this is the family pedigree of the patient. Right, this is the patients, and this is the mother, and this is the father. Right, the mother, when we test the mother is not a carrier, neither the father. So the rest of the sibling, the eldest, the second, the third, all of them, are boy, and they are well and clinically do not have any presentations of clinical, bleeding tendency. And when we go back, to the earlier pedigree of the mother, there was a history of, not that there was a history. The maternal auntie, okay, have 4 sons, and all of them are well. And we do not know whether here the father died because of what, but it is very not relevant when you talk about the inheritance of hemophilia. So this is where that, what we say about 1/3 of babies who are diagnosed with hemophilia have no other family members with the disorder. So spontaneous mutation can occur. And when we send, a detailed, the genetic test for this patient, we did not find that, the parents affected in any form of, any form of, what do you call that, carrier or, hemophilia in the family. So in the end, we concluded that this patient has, a spontaneous mutation. We are entering into another poll question. So this is quite, busy slide, but I believe you can read it very quickly. The following statements is or are true on the genetic inheritance of hemophilia when the mother is a carrier of the hemophilia gene and the father doesn't have hemophilia. It is a multiple choice question. And this is a factual question. I guess it's going to be very easy for you all, right? So you don't need to have a long time to see the results, Jeremy. Ah, 60% answered number 1. 47% answered number 2, 30% answered number 3, and 23% answered number 4. This is factual. So number 3 and number 4 are wrong. Right. So we move on to the next slide. Another poll question. The following statement or statements are true on the genetic inheritance of hemophilia when the father has hemophilia and the mother doesn't carry the hemophilia gene. Yes, can we see the answer? 67% answered all daughters will carry the hemophilia gene, correct. 55% answered no sons will have hemophilia, correct. 27% answered number 3 and 12% answered number 4. Number 3 and number 4 are wrong, yeah? So number 1 and number 2. Okay, good. Right. So I move on to the next slide. The patient received plasma-derived CFC, which is factor 8 alpha-net. This is the brand name. Dosage, when we prescribe dosage, is going to be patient tailored and also depending on the pharmacokinetic of the drugs itself. Okay, so for this patient post CFC, the factor 8 level increased to 33%, and the hematoma and bruises resolved after 1 week. Patients were counseled on bleeding tendency, preventions of bleeding, immunizations, and home care, and he was scheduled for regular follow-up. This is a very busy slide, but it's just to highlight to you, if you follow my arrow, that I wanted to highlight to you that, you know, in a multicultural community, a nation, you know, that have a different understanding and different belief, it might give you a big challenge to treat patients with hemophilia. And you have invested a lot of money, a lot of, you know, allocation to treat the patient. So once you started, when you had determined the regime of treatment for the patient as much as possible, you would try to make sure that, you know, the treatment regime is adhered to. Okay, so for this patient, okay, when he went home at different month of age, 5 months old, 7 months old, okay, 9 months old, the patient have episodic recurrent hematoma at, you know, different sites. And even the patient developed, you know, hematoma after subcut immunization. But, you know, the parents did not bring the patient to seek any treatment. And, you know, at 7 months old and 9 months old, the patient have, you know, episodes of hematoma on some part of the body. And at 9 months old, when the patient presented to us, we started the patients on prophylaxis. And, you know, we observed the patients to monitor whether he have, you know, reduced and or zero bleed, you know, condition. At 13 months old, unfortunately, the patient come back to us, you know, with multiple bruises and for a certain period of time. And when we checked the inhibitor level, it was raised. Then we stopped the prophylaxis, and then we started, you know, and we discussed with the parents, okay, about prescribing and starting the patients on, you know, bypassing agent. So the patients, you know, receive bypassing agent. I have to refer this patient to another center because our hospital do not want to absorb, wouldn't be able to absorb the cost for the bypassing agents. And, you know, at the other center, they have some compassionate basis being subsidized by the government to purchase, you know, the bypassing agent. So just to illustrate to you that, you know, during the course of disease itself, right? During the period of inhibitor development, we have, we struggle with treating the patients with bypassing agent, and the regime was quite intensive. And, unfortunately, the patients has not been fully responded to our ITI. And mother have, concerned that, she went into frustration that the so-called that, response has not been achieved, as expected. So we still pursue with, counseling the parents, seeing the parents often, and try as much as possible, okay, to treat with, according to whatever manifestations that the patient has. So during, 2 episodes, we also prescribe the patients with oral tranexamic acid, okay, because the patients have, some form of mucosal bleeding apart from this buttock and forearm hematoma, right? Then, at 2 years old, the patient was started, with ITI, when parents has agreed upon, okay, at last parents agreed upon the ITI treatment. So we started the patient on, and, up to the period of time that patient have what do you call that, problems with repeated episodes between 2 years old and 4 years old. So he received ITI and also clotting factor concentrates during this period of time, and he managed to tolerize after almost 2 years of ITI, and the inhibitor level was undetected then at that time. So the CFC dose was weaned down stepwise until to the dose of prophylaxis, and now currently he's well on prophylaxis. Just to show you that, this was the bleeding that, when the patient developed the inhibitor. It was quite a huge bleeding on the buttock, and mom has kept the patient for a few days, before the mother brought the patient to the hospital. And when the mother agreed upon, ITI, we inserted Portacat, underneath, and this is used to deliver the regime of the treatment. So it minimized, injury or bleeding when you are assessing, IV granula to the patient. Okay, so those are the, yep, so that's the end of the case presentation, and we are entering another poll. I guess this is the last poll question. The following are some of the advice you would give to the parents of the child. Again, that it is a multiple choice question. So yes, very good. You have 94% who answered adherence to prophylaxis. 58% answered he can receive intramuscular injection of routine vaccination. No, that's wrong. Okay, he can play football. 9% answered that. No, cannot, because that is a contact sport. 33% answered he can go for cycling, play badminton, or swimming. Yes, okay. So the correct answer is that he can go for cycling, play badminton, or swimming. Okay, and adherence to prophylaxis. So very much we advise patients not to play contact sports, and football is associated with contact sports. Okay, and vaccinations all must be received, through subcut or subcutaneous, not intramuscular. Right, so I can't move my slide, it's freezing. Yep, okay. So that's the last poll questions that we entered. So 1, yes, 1 and 4, okay. All right, so in conclusion, it is very important when you are moving to the next phase of your career, because now you are a medical student and your next career is you are fresh graduate and you are, very energetic group of doctors, which at point of time, you might encounter a patient who is suspected to have hemophilia. At one point of time, you might be dealing with hemophilia patients, okay? So it is very important that, your country or your center or your region must have a national coordinations and deliver the care, for the hemophilia patients. You must ensure that, you have a good access to safe CFC, laboratory services, the minimum requirement of laboratory services, not talking about genetic diagnosis if you can't offer that, okay? And education and training is very, very important to the help, professional, healthcare professional, patients and caregivers. Even, we are doing, continuous and intermittent, workshop to, healthcare professionals, including the doctors, including the nurses, including pharmacists, psychologists, etc. Okay, for them to understand about acute and emergency care of bleed, the importance of multidisciplinary care, the importance of moving or achieving, aiming towards prophylaxis, and how that you manage your complications, especially the musculoskeletal and the joint system, and how that you want to use your outcome assessment to guide you with managing the patient. And of course, last but not least, is always a challenge. How established is your team or your center, you will still have, ongoing challenges. And, one of the very important is adherence to treatment. It is not just talking about developing countries or low income or middle income countries, okay? Because adherence to treatment might have, needing you to factor in a lot of issues. Even the educated parents also might have problem with adherence, okay? So these are very important take-home message that, you might want to think of, all right, when you encounter patients with hemophilia, all right? So as I mentioned to you, role of medical students and fresh graduate clinicians are all incorporated, throughout my talk just now. So with that, yes, Lorraine, we have the same closing slides, okay, which is today is the Hemophilia Day. It's just that we don't wear the red color shirts, isn't it? Yeah, Jeremy? Okay, with that, I thank you for your kind attention. It is lovely to see, so many students from many countries and, you are participating in the poll question. Thank you very much for the invitation. Yep.
Thank you.
I will stop sharing. Can you?
Yes, I can assist with the stop sharing. Thank you very much, Prof. Hamidah Alias, for the comprehensive lecture about the treatment of hemophilia. And I would like to inform us that all the questions that have been collected on the Google Forms will be collected and will be answered by the speakers in the post-event booklet. So there will be no question and answer sessions on these lecture sessions. And we will proceed to the appreciation session next. And I would like to resume all the lecture sessions for today's session. So hemophilia is an inherited disease that have been problems from a long time ago until now. So therefore, prompt management, initial diagnosis, and prompt treatment should be taken to improve the quality of life, to reduce the morbidity and mortality of hemophilia, to improve the quality of our patients. Thank you very much, Dr. Lorraine and Prof. Hamidah, for joining us today and for providing us such good information on hemophilia for us medicine students to use on our daily and practical life. Thank you very much. And I would like to present the certificate to Prof. Hamidah and Dr. Lorraine. First one is for Dr. Lorraine. I would like to take a screenshot of the Dr. Lorraine with the certificates in 1, 2, and 3. One more in 1, 2, and 3. Thank you very much, Dr. Lorraine, for joining us. And we now proceed to Prof. Hamidah to receive the certificates from AMSA International. We will take photos in 1, 2, and 3. One more. In 1, 2, and 3. Thank you very much, Prof. Hamidah, for joining us. And
my pleasure.
Dr. Lorraine for joining us. Now you are free to leave the meeting room and I will proceed to the next agendas.
Right. Thank you very much for the invitation. All the best.
Yes, thank you very much as well. Now we proceed to the next agenda, which is the post-test and feedback form. So in order to get the certificates and in order to get the post-conference book, you need to fill the post-test and feedback form in this tiny.cc/WHD WSDW AMSA2. So you must fill the post-test and feedback form in order to get the certificates. Now we are proceeding into the next agenda. Now we are proceeding to the next agenda, which is the competitions and results announcements. So we are moving to our World Haemophilia Day competitions. Thank you for every participants who have been submitting their works into these competitions. And now we are going to announce the results of the public poster. So congratulations to the public poster. In the third place is Kurnia et al. With Haemophilia, Reject the Myths, Remember the Facts. In the second place is Firdaus et al. With Safer Haemophilia with the HFA, Haemophilia for All. And the first place, we would like to congratulate to Treat Them Specials, as practical guide for parents to educate their children with hemophilia by Dison et al. And in this very opportunity, I would like to ask the first place to present their works. To the first place, the stage is yours. Thank you.
Okay, thank you very much for the opportunity. I would like to share my screen. Okay. One.
Okay, you may proceed now.
Okay. Did you know that while we are talking and living freely at the moment, there are millions of children out there, children with hemophilia, that live a boring and hopeless life? So the question is, what can we do about it? Good afternoon, ladies and gentlemen. Today, we, Nathaniel Gilbert, Priscilla, and Violin, kindly invite you to raise our awareness together towards this issue. Hemophilia is an inherited bleeding disorder. Someone with hemophilia cannot stop bleeding because they don't have enough clotting factor in their blood. It is considered to be a rare disorder with only 400 babies being born each year with this condition. Unfortunately, studies have found that 52.9% of children with hemophilia today had impaired quality of life that affected their health. Overprotective parenting style and with high discipline and restriction on many activities have been done to children with hemophilia in the name of protection.
On the other hand, a lot of myths and stigma have been placed on children with hemophilia. As for example, a small cut causes blood to rush out and the children will bleed to death. Others might even say that they could never live a happy life playing together with their friends.
But the fact is actually the opposite. Someone with hemophilia will bleed longer than normal people, but not faster. Thus, children with hemophilia can have a normal life and play with their friends with extra attention and carefulness.
That's right. Therefore, we proudly present our public poster titled Treat Them Special, a practical guide for parents to educate their children with hemophilia.
To remember the steps, we must put in mind first that children with hemophilia are special, as for stop restricting children from playing with their friends. In fact, socialization and communication between childhood friends are very important for a child to grow and develop optimally. P, for physical activity is required regularly. We understand parents fight for their children to get injured while playing or exercising with their friends. However, several studies have shown no significant increase in risk of bleeding for children with hemophilia when asked to do more intensive physical activity, such as swimming, dancing, walking, and yoga. E, for enroll your child in a hemophilia treatment center. This is the place where you and healthcare providers Leaders can discuss the appropriate treatment strategy for your beloved child's health.
Next, we have C for check with your doctors before any medical procedures. Doctors understand the condition and can inform you about the most non-invasive procedures which you can choose for your children to reduce the risk of injury or bleeding. And next, we have I for regularly inspect child's oral hygiene, as this might prevent the need for dental visits and risky procedures.
Next, we have A for advance their confidence and optimism because hemophilia is a lifelong condition without any cure available currently. That is why it is very important to learn how to inform their condition to other people and to accept it the way it is. And the last one is L for let child understand how to recognize and treat minor bullying as parents might not always be with them, for example, during the school time.
So, we choose the word special as the mnemonic to remind the readers that children with hemophilia is truly special. They do not deserve to be locked at home and isolated from their friends. They must be treated with extra attention and carefulness.
In conclusion, please remember to treat children with hemophilia with special, because they are truly special and deserve a bright and fulfilling life. Thank you very much for your attention. Let's overcome the burdens of hemophilia in children together. Treat them special.
Special. Thank you very much.
Okay, thank you very much, Nathaniel, Violin, and Priscilla for the great presentations for the public poster branch of competitions. Now we are going to proceed with the next announcement on the competitions. Okay, so now we move on to the other branch of the competition. So we will have scientific posters announcement of the competition results. We would like to congratulate third place, Vigneswara Divi et al. With the work of factor affecting hemophilia in pediatric patients. The second place is Ashura et al. With effectiveness of low-dose factor VIII prophylaxis as an alternative management in resource-limited settings for hemophilia A in pediatric populations, a systematic review and meta-analysis. And first place, Mila et al. With recombinant versus plasma-derived factor VIII concentrates on inhibitor development in previously untreated patients with hemophilia A. With hemophilia. 2021 update of systematic review and meta-analysis. Okay, to the winner, to Milael, we give you the stage. Now the stage is yours.
Excuse me beforehand, the announcement of the title is different from the article from the scientific poster that we submitted.
Yes.
Is it right?
I haven't edit the announcement yet. Thank you very much for the corrections.
Has the slide sharing be shown?
Yes, you may proceed.
Good morning, good afternoon, and good evening to wherever our medical peers are. Today, we are very grateful because AMSA International has given us the opportunity to present our study. Our study is about oral bioencapsulated coagulation factor IX fused with cholera toxin subunit beta 13 as a promising immune tolerance induction therapy for hemophilia B. Systematic review. Here are me and my friends Salma and Belinda will present our study today.
Standard therapy for patients with hemophilia B is prophylactic bleeding of neutralizing antibodies for immune challenge antibody eradication by immune I preferred as the management strategy for treating patients at high dose for prolonged periods as method to eliminate inhibitors and to restore effectiveness of factor replacement therapy. Despite the availability of ITI as an option to eliminate inhibitors, the extremely high cost of ITI is a major disadvantage. Moreover, ITI itself cannot be completed if a patient develops anaphylactic reaction. Incredible advances in bioengineering offers a potential solution to the aforementioned challenges in hemophilia, and this review aims to evaluate the efficacy of an oral delivered factor IX fused with cholera toxin beta subunit bioencapsulated in plant cells to suppress inhibitory antibodies formation and to prevent anaphylactic reaction in published preclinical studies. For the method, we collected studies from various databases using keywords and Boolean operator and was processed based on Prisma statement. Each of the studies were assessed for their quality using circle risk of bias tool. The initial search yielded a total of 26 studies and was then screened for their eligibility based on inclusion and exclusion criteria, which resulted in a final of 4 studies included for this systematic review.
And here's the summary of 4 included preclinical studies which has been identified in our systematic review. Total sample size is 116, consisting of 44 controls and 62 interventions. 3 studies used mice and a study used dog as the animal model. Half of the studies used PLD chloroplast to deliver factor IX, and PLS was used for the remaining studies. As intervention, oral coagulation factor IX fused with cholera toxin beta subunit with or without a furin cleavage site is administered towards the animal model. And here are shown the quality assessment of the studies using circle tool. As shown in the graphic, animal model that had received oral tolerance using CDB factor IX with or without furin cleavage had lower or suppressed factor IX inhibitor, IgG1, and IgE titers in contrast to the control animal model.
Before understanding the mechanism of action of this idea, we need to understand first what is a patient with hemophilia B. A patient with hemophilia B is experiencing deficiency of factor IX, but in this case, the patient is actually having immunological reactions towards the factor IX that he or she actually needs. In order to address this situation, it is suggested the idea to administer factor IX in high doses orally with a capsule. So the bio capsule is being administered orally so that the factor IX can be enclosed towards the intestinal epithelial cells. The cholera toxin beta function is to bind with the GM1 ganglioside receptor complex on the intestinal epithelial cells, and therefore can transfer the factor antigen towards the antigen-presenting cells. In this case, is CD103 plus dendritic cells, so that by presenting the antigen of the factor IX, it can actually change the naive T cells into T regulatory cells. And here are LAP plus and CD25 plus CD4 plus T regulatory cells. And we all know that the T regulatory cells produce anti-inflammatory cytokines such as interleukin 10 and transforming growth factor beta, so that it can inhibit the production of inhibitors. Therefore, from the results and discussion, we can conclude that the oral delivery of bioencapsulated factor IX fused with cholera toxin beta successfully showed suppression towards the factor IX intolerance and also the related hypersensitivity reactions. And further research of this idea for human clinical trials is strongly suggested. Here are the references that we use. And lastly, we are very thankful for all of you for being here today. We are very honored to be given this opportunity for a presentation.
Thank you very much, Mila, for the great presentation, and congratulations again for the scientific poster winner. And we are proceeding to the last presentations, but not least, of the winners of the scientific paper competition. So we are going to announce the scientific paper winner. So the third place, congratulations to Mila et al. With the efficacy and safety of emicizumab for treatment in mild hemophilia, a systematic review. And for the second place, we would like to congratulate Penantian et al. With exploring the efficacy and safety of factor VIII mimetic function of humanized bispecific antibody in classic hemophilia patients with or without inhibitors, a systematic review and meta-analysis. And we would like to congratulate the first place of Kohar et al. with recombinant versus plasma-derived factor VIII concentrates on inhibitor development in previously untreated patients with hemophilia, to 2021 update of systematic review and meta-analysis. To the first winner, the stage is yours.
Okay, good afternoon, ladies and gentlemen. Before we start, we would like to introduce ourselves first. My name is Stephanie, and I'm here with my friends, Kelvin and Loie. And today, we will give a brief presentation about our paper with the title of Recombinant versus Plasma-Derived Factor VIII Concentrates on Inhibitor Development in Previously Untreated Patients with Hemophilia A, a 2021 update of systematic review and meta-analysis. Next. Here is the outline of our presentations. Next. So hemophilia is a genetic condition that cause prolonged bleeding and may be difficult to control due to inadequate clotting factors. Hemophilia is found in 1 out of around 3,000 people, with hemophilia A comprising 80 to 85% of total cases. Next. Current hemophilia A best treatment is to replace the missing clotting factor, which is factor VIII. However, it is reported that replacement therapy is capable to induce inhibitor development in 30% of patients with hemophilia A. As one of the factors affecting the development of inhibitors, choosing the right type of replacement therapy, either plasma-derived or recombinant, can be a way to reduce the probability of inhibitor development. Next. Even though systematic reviews have already been conducted in 2010 and 2012, the significance of the results were not shown. It is also only included one arm studies, which results in ambiguous data and remains inconclusive. Thus, as more studies have been done, an updated systematic review and meta-analysis are needed.
So the systematic review is done by adhering to the PRISMA statement guideline, starting with the letter to search in 3 scientific databases, which is PubMed, Science Direct, and Scopus. And then we did a screening with the predetermined PICO and eligibility criteria. And then we continue to do the data extraction and quality assessment of the included studies. And we pursue the pooled data by using data extraction and do a quantitative analysis using Refman to have an outcome of cumulative outcome for all included studies.
Next. Now we are going to talk about the result and discussion. In this systematic review, we included 9 retrospective cohort studies conducted in various countries with a total of more than 2,000 hemophilia A patients, which most of them were children and followed since birth until death. Next. This figure shows 2 forest plots depicting the association between factor VIII types and overall inhibitor development based on pooled odds ratio and hazard ratio. For your information, inhibitors are neutralizing antibody that leads to the inactivation of factor VIII products. As you can see, the recombinant group shows higher inhibitor development compared to the plasma-derived group with pooled OR of 1.57 unsignificantly, as shown in the first plot, and pooled HR of 1.89 significantly, as shown in the second forest plot. Next. The same result also obtained in high-responding inhibitor development, which recombinant group was associated with unsignificantly higher development of high-responding inhibitor with OR of 1.38 and HR of 1.42. Next. Our findings were supported by Franchini et al. In overall inhibitor and Iorio et al. In high-responding inhibitor. Both studies reported that inhibitor development was slightly higher in the recombinant group compared to the plasma-derived group. Next. Some limitations in our study are the variation in the duration of recruitment period that may be affected by drugs development, and some studies did not report the subclasses drug used. Nevertheless, our study has some key strengths as well. The included studies have low risk of bias, and study designs included are capable in evaluating long-term inhibitor effect. Not to mention, the variation of countries also makes the results can be implied globally. Next.
To summarize, this comprehensive meta-analysis demonstrates that recombinant factor VIII is more likely to cause inhibitor development, either overall or high responding, compared to the plasma-derived factor VIII. Future recommendations from our study is to analyze directly the associations of drug subclasses and the inhibitors development. Future research approaching the safest treatments without inducing the inhibitor is also necessary. Next.
Okay, here is the end of our presentation. Thank you for your attention. If you have any further questions, do contact us through my email. Thank you.
Thank you very much, Calvin and friends, for sharing such insightful presentations about the scientific paper about the hemophilia. I hope that's all will give us a good insight for us all. And that marks the end of this webinar. We would like to thank you all the participants and all the speakers and all the winners for presenting in this webinar. And last but not least, let's take a photos of our webinar. You can open your camera and we will begin to take a photo soon. Okay, I will try to taking the picture. In 1, 2, and 3. This is the first page. We move to the second page. In 1, 2, and 3. Now the third page in 1, 2, and 3. Thank you very much, everybody, for joining us. I hope you all have a great weekend ahead. And thank you very much for celebrating World Haemophilia Day with us. I hope this event can give a good impact towards the hemophilia and towards the people all over the world. Thank you very much and see you on the next event of AMSA International. Thank you, stay healthy, stay happy, and have a nice weekend.